Welcome to the SJMC Grandrounds, where our experts come together and discuss challenging cases. Witness a synergy of intellect and medical expertise as we embark on our continuing medical education journey together. Before we start, I would like to remind you to subscribe to our channel and enable notifications so as not to miss our upcoming episodes. Now let's begin.
Hello, everybody, and welcome to our SJMC Grandrounds number 36. And with me today is Dr. Kanan, who will be chairing the session. Hi, Kanan, and consultant vascular surgeon, Dr. Liu Ngo Chin. Okay, and not in the camera yet because you can see under my name, it's Alante / Jayamala. Dr. Jayamala will join in a little bit later. So today's webinar is on peripheral vascular disease, early detection and proactive care for better health. So we hope the cases presented here will be of interest to you and help you in your practice. Just some housekeeping slides. We will be taking questions and answers at the end of the session using Slido. So the Slido code is 1030798. You can use your QR code scanner from your camera or QR code app and scan. It will take you to the same slido.com link and you will enter 1030798 for you. If you're using the Slido app on your phone, you can just enter the code and it will take you to our event. Please do subscribe to our channel because if you do so, YouTube will keep you updated on our upcoming sessions. Okay, so without further ado, I will hand over to the chairman, Dr. Kanan. So take it away, Kanan. Okay.
Thank you, Alan, for the introduction. Good afternoon, ladies and gentlemen. It's going to be an interesting session about peripheral vascular disease. We don't talk about this very often, but it's a very important disease to diagnose because timely intervention and referral will make a difference to whether the patient keeps the limb or loses the limb. So we'll dive in straight away with the first case. This is a patient who was 70 years old in is 70 years old in 2024. He was first seen in our institution in April of 2011 when he came in with an emphysema of a gallbladder. He had a very stormy course, but he was noted to be in atrial fibrillation at the time of admission. No one knew how long he had been in atrial fibrillation. He gave a history of having hypertension for about 20 years. So the echo at that time was reported in the record as an ejection fraction of 40% with concentric hypertrophy, which would be keeping with his hypertension. It has stormy course in the intensive care requiring inotropes, intubation, ventilation, and he survived all that. And then he survived. 9 years later, he saw me for the first time when I was on call. He accompanied with complaints of 1 week of apnea, no chest pain, mild leg swelling, no symptoms at rest, no diabetes, never smoked, no alcohol consumption, denied palpitations, had no medical supervision for his hypertension like many of our patients do. They just buy medication from the pharmacy and consume. And his drug was Nebivolol 5 milligrams once a day. He also gave a history of psoriasis for which he was on treatment with methotrexate from a dermatologist at Sunway Hospital. So clinically, this was a very obese man, really huge. Can't sit in one of the usual hospital chairs. When he comes here, we get 2 chairs for him. No edema, jugular venous pressure not seen, blood pressure 160 by 100, so certainly not good control. Atrial fibrillation, the ventricular rate was 106, so certainly the atrial fibrillation was also not well controlled. Examination of the heart, sounds, nothing special, lungs were clear. Abdomen was obese, so he had striae. The skin appeared thin. So looking at him overall, of course, one thought he might be on chronic steroid therapy, but he denied consumption of steroids, denied taking steroid creams or traditional herbs. So the diagnosis then was hypertension with hypertensive heart disease, atrial fibrillation. We thought his heart failure could be both suboptimally controlled hypertension as well as uncontrolled atrial fibrillation. There was still a suspicion of chronic steroid therapy, which could have contributed to his symptoms. Of course, psoriasis, which had been confirmed. Now, the ECG at that time showed atrial fibrillation, ventricular rate was 100 per minute, the chest X-ray showed a huge heart, the lungs were clear. I'm just running through this because this just gives a background and then we'll get into him later. So the blood profile, nothing very exciting except the creatinine was a bit high at 114 micromoles. Electrolytes were okay. Albumin was low at 26. The liver enzymes were okay. So we aim for rate control. You see that in orange. So rate control, we use amiodarone, digoxin, and a beta blocker, nebivolol. For heart failure, we use furosemide, spironolactone, and of course the beta blocker also helps. We had used, this was 2020, so we're not very hot on SGLT2 for heart failure, and didn't want to spend extra money, so we used valsartan, but we had to stop it because the blood pressure was low. And for anticoagulation, we use apixaban 2.5. I admit the dose is low for his size. We would require 5 milligrams twice a day. So symptomatically, he got better, and by the 28th of October, his creatinine, as you can see, has improved, and then he disappeared. After November 22, 2020, he defaulted for us. And then when we saw him again, he said he stopped all medications, and he said that the first course of medicine had cured him. Then I got a call on 30th of July, 2021 from my friendly vascular surgeon, Dr. Liu Mo-Chin, to say that the patient is here, his leg looks black. And Dr. Liu's case note showed that for 1 month, the patient had complained of severe calf pains when walking less than 200 meters. And for 1 month, the distal foot had progressively become painful and discolored, and was treated by a family physician with antibiotics and local liniment. I think this will be relevant to discuss later. Suppose we had another chance and you were the general practitioner seeing this patient, what you would have done. When I went to see the patient, she had obvious gangrene in the distal aspect of the left foot, as you can see on the slide. Blood pressure was borderline 100 by 80. Atrial fibrillation was not under good control. The rest of the exam was normal. So this was his ECG. As you can see, it's a completely irregular rhythm. There's nothing else that's very significant, perhaps a small Q wave in retreat. The ventricular rate is probably about 100 per minute. Yeah. Chest X-ray, gross cardiomegaly, and one could say that there's some pulmonary congestion. So left ventricular failure, not surprising given everything. And this was his echocardiogram. Essentially, it shows the left atrium, which is a big round chamber right at the bottom on the right that is dilated. The ejection fraction is reduced, but very hard for us to judge ejection fraction when your ventricular rate is not well controlled. Essentially, the valves were normal. So this is atrial fibrillation, non-valvular atrial fibrillation. And I thought that maybe we could ask, Dr. Liu is going to take over the discussion. And I thought maybe we can address a few questions. What can we infer from the history? What differential diagnosis would we consider contributing to leg pain? Is it just peripheral vascular disease or other things that we should think about? What investigation should we do? And what results Dr. Liu got? And you'll find out what the diagnosis was. So in that situation, options are very limited. And Dr. Liu will tell us what he did. Take away, Dr. Liu.
Can you change the screen?
Okay.
Thank you. So, Kanan, thanks for seeing this patient. Basically, from this gangrene, you can see he has actually limb ischemia. Just to summarize that, he has a one-man history of severe lower limb pain, and then the toes apparently became gangrenous. Prior to that, he did have claudication. He did not come to the hospital immediately because he was completing his dose of a Sinovac vaccine. So he thought it's okay to just wait for a while, taking some painkiller. I think we made diagnosis of ischemic heart disease, congestive cardiac failure, atrial fibrillation. More importantly, he has actually defaulted his apixaban. Not sure how long. What struck me at the time was this guy is really obese. His weight is 123 kg, BMI 46. And his left lower limb, besides the gangrene, he's got no pulses from the femoral down. The contralateral limb, the pulses were palpable. So this is what the limb looked like. Well, you can see there's obviously gangrene involving the lateral four toes. There's also one gangrene at the in between. It's in the first fab space. There's a lot of inflammation and he's in a lot of pain. So, as a vascular surgeon, what's important to me is to make a quick diagnosis. Is this an acute ischemia or is this a chronic limb-threatening ischemia? Previously, we used the term critical limb ischemia. It means a chronic ischemia that progresses, then it became acute again. So it's acute and chronic ischemia. But right now, the nomenclature they like to use is chronic limb-threatening ischemia. If it's acute ischemia, I have to intervene immediately. If it's chronic limb-threatening ischemia, then we still have some time for us to intervene. So most of the time, we make the diagnosis clinically. And sometimes we can actually supplement with Doppler, duplex scan, or CT arteriography. But in this case, based on his history of atrial fibrillation and not taking his apixaban, also based on his sudden onset of very severe pain in the lower limb, so very likely that this man has got acute limb ischemia secondary to embolism, in which case then we have to treat him quickly. So he underwent a CT.
And can I just ask Dr. Liu, okay, this history has been going on for about a month already, and you still say it's acute. The usual understanding is it's acute, it tends to be days, you know. So how would you say, is it acute on chronic or is it an acute?
So it's a bit difficult to, sometimes the two things merges. The reason why we need to distinguish between the two is because the management's time sequence is entirely different. If you see a patient with acute limb ischemia, you have to refer immediately because there's ischemic time of about 6 hours, maybe up to 8 hours. But if you refer later on, you find that then you find sometimes the limb may not be salvageable.
Okay, as a GP, okay, let's assume that the patient came to see me. What advice could you give me as to how I should refer to you? Should I treat him first and then refer to you later? I mean, if he had come to me and I was the GP treating him, what would be my advice to him?
Unfortunately, you find that ischemia has a time limit, and if tissue is acutely ischemic, then you find that sometimes when patient was sent to us, it's already irreversible ischemia, so there's nothing much you can do about it.
My question is, because most time from my understanding, if it's an acute ischemia, the leg would have become blue, gangrene. I mean, blue, very cold. Then we know at once we must refer this patient to the hospital as far as possible because an acute ischemia. We do understand, but this man has been having history for 1 month, and okay, he came to see me in week 2. To me, what were the signs which would have told me that, hey, this is something I shouldn't be, it's not an ordinary infection. I mean, I would have been treating him as an infection with antibiotics and, and I thought that gangrene is infective. So what clues could I have been looking for?
Yes, I think basically there are very few events in medicine where people can remember the time. Embolism is one. They were perfectly quite normal, and then suddenly the pain came in very severely. They were not able to walk. It's just like stroke. A minute ago he was perfectly well, and suddenly he can't talk, and then he died suddenly. So actually, it's the suddenness. But you can also argue that the suddenness, he didn't come, and then you just leave it alone, don't do anything, then it progresses to gangrene. Then it depends on where the embolus sits. If the embolus sits in the aorta, we call it a saddle embolus. By the time they come to the hospital, they'll be too sick. Most of the patients die. But if the embolus goes down the common femoral artery, it sits down there, then if they don't come acutely, you find that then they will actually develop, they will lose a limb up to above knee amputation. But if they're lucky enough, the embolus goes further down. It bypasses the profunda femoris artery. That's where you find that ischemia can be less severe. Then they can actually, the collaterals can come to profunda femoris artery, reconstitute the distal artery.
Can I ask, maybe make one simple suggestion? One of the things you mentioned in your clinical examination was the absence of pulses. Often I find that when people do clinical examination, one of the things that people don't do is to bother to check the pulses. So if I'm sitting in my general practitioner's clinic, if I just put my fingers and the pulses are not there, maybe the thing I should do is refer to a hospital where you can take over, and everything else will be quite academic actually.
I agree with Kanan. I think so. Basically, you see someone like that. I think the important thing is feel the foot pulses. I think that's a simple take-home message, I guess.
Yes, I think look for pulses. Then acute limb ischemia. There's a 6 P's. Pulselessness, perishing cold, pallor, pain, and then if it progresses, they actually go to their paresthesia, then they go to paralysis. But we do not want to reach the stage.
But like you said, if the embolus is sitting below the profunda femoris, we may not get the 6 P's because of collateral. Correct. So a simple thing is just feel the pulses.
Yes. So this is the CT arteriography. Now that he has waited 1 month, we think we have time to do CT arteriography. As you can see in this CT arteriography, that on the right side, the vessels are not too bad. You can see the superficial femoral artery, popliteal artery, go down to the anterior tibial and posterior tibial artery. But on the left side, the upper arteries are quite well seen. However, up to the popliteal artery below that, there's actually occlusion of this popliteal artery, and you can actually see the seal hole of thrombus within this popliteal artery, and the trifurcation is not very well seen. The other is just a plain CT, just to show you that this is a very obese man, and with all this, pendulous tummy. So the decision at the time we made was this man has got acute limb ischemia, he's got embolism. However, treating him is a bit of a challenge, because if we were to take him into operating theater, to get to the femoral artery, he needs probably some kind of regional anesthesia or general anesthesia. And so with this obesity, that's operating on him is a bit daunting. And since he waited for quite a while, we thought maybe what we'll do, we try on with this catheter thrombectomy and thrombolysis. Catheter thrombectomy, we can actually do it percutaneously coming from the contralateral side. On the right side, we then cross over to the other contralateral left iliac artery, and then maybe you can try to do catheter thrombectomy and thrombolysis. However, because the embolus has been there for nearly a month now, it's organized thrombus, so it's not so easy to just suck off this thrombus. So perhaps using this echoes is actually ultrasound associated thrombolysis. So maybe that will be able to help remove the clot, and then we are able to take out the clot. Basically, when you have embolus, the right thing to do is to do embolectomy. However, this is a delayed presentation, and with his multiple comorbidity, so we thought we'll give him a trial of catheter thrombectomy and thrombolysis first to see what happens. He had a CTA done. The catheter angiogram shows there's dense occlusion, popliteal artery and TP trunk. At that time, we were half-hearted. Maybe we should take him to operating theater, or maybe we should just proceed with the echoes. But operating theater, you find that there's no slot at the time. You have to wait for many hours. So we thought, okay, in that case, let's proceed with echoes. So we use echoes-assisted thrombolysis. We initially press for 24 hours to see what happened. And then if we cannot, then we have to go through this open surgery under local anesthesia and some form of sedation. Just to show you the catheter angiogram. Catheter angiograms, we put in the catheter into femoral artery, you can actually see the whitish structure inside there. It's in the popliteal artery. That's actually the thrombus or the embolus. Then you can see the other angiogram. In the middle one is tibial arteries. It's one very poor flow going down. And the third one is the arteriogram of the foot. We find that flow going down is quite poor, but there is some flow coming through these collaterals because the embolus has reached the popliteal artery. So these are coming from the branches of the profunda femoral artery. And so we put him on echoes. On this, you can see there's echoes catheter. It's a form of thrombolysis using this ultrasound. And then the ultrasound can actually break up this thrombus and allow this thrombolytic agent to penetrate the clot and try to lyse it. There is some improvement, but you find that the runoff into the food is still very poor after about 48 hours. At the juncture, we thought if we leave this alone, no, this clot won't be able to come out. This is pre and post. You find that there's not much improvement. And so then we have to eat the frog, bring him to the operating theater, and then face the, try to take out the clot using an open method. You can see this guy is very obese. It's quite daunting to make an incision into the groin. And he also got a catheter. It's a femoral sheath into the left common femoral artery. And so what we did was we made an incision under sedation and local anesthesia. We took out the sheath, and then make an arteriotomy. Then we actually use an embolectomy catheter to fish out the clot. You can see it's a really long clot. And this one that's blocking the artery, causing his ischemia. And this clot is not a jelly, it's like very organized clot. So it's consistent with the history of presentation of about 1 month. And so normally after a revascularization, when you have a bit of a cyanosis, immediately there's a demarcation line between living tissue and dead tissue. Dead tissue becomes more black. Living tissues is what you call it's light color. You can see there's actually a big difference. And then once revascularization occurs, at the same time, now the blood is going down. There's actually a tissue reaction. There'll be white blood cells going down, and all that. So there'll be some infection. And sometimes they actually start to learn fever and so pus formation. So we waited for a week when the whole thing has been demarcated. Then we go in to actually do this toe amputation. So he ended up with removing all the toes, and you find that this is what happened. And then he was in a ward. Because of his obesity, we are quite worried that he may develop pulmonary embolism, and is adequately anticoagulated with subcutaneous Clexane. And this tissue looks a bit sloughy, and he underwent another episode of debridement. Just to show you the progress, embolectomy is done on August the 3rd. By the time he get to go home is October the 3rd. So really, this is nearly 2 months in the hospital. So a bit stormy. He had 1 week after embolectomy, he underwent transmetatarsal amputation. The tissue grew proteus and pseudomonas. 3 weeks later, another debridement. Then we put him negative pressure dressing. Very importantly, this man was, we pressed him very hard. So Kanan did a good job of warning him that he lose his leg, so that we need to mobilize him. The other complication that can occur is, deep vein thrombosis and then pulmonary embolism, things like that. But we managed to get him up and about, and then he actually went home 2 months later with a pretty good result.
So, what is negative pressure dressing?
Negative pressure dressing is a new form of dressing. So what we do is we apply negative pressure on the wound. And what this negative pressure does is actually it creates an oxygen gradient, so that there's no more diffusion of oxygen down into the tissue and coming out. At the same time, we remove all this exudate and the bacteria. It also causes wound contraction. So in this negative pressure dressing, the advantage is a new form of dressing that you can put the dressing on and remove it after every 5 days to a week. So you don't have to do it every day.
Is it like a gadget or something that you put it on?
Yes, it's a gadget. It's just a occlusive dressing, and then it's connected to a small tube, and that tube is connected to a device. And it used to be the device is connected to a machine, but these days the device you can actually hang it and then you can still walk around. So negative pressure is now it's quite popular in helps in wound healing.
Would you consider, now that you're revascularizing, do you think there's a role for hyperbaric therapy to clear his wound?
Yeah, you can do hyperbaric therapy. But the key thing about hyperbaric medicine treatment is that you need to make sure that there's perfusion down the tissue. So in how hyperbaric works is that in a normal person, the hemoglobin, the oxygen is carried by the hemoglobin. And up to 98.4% of the hemoglobin is saturated with oxygen. So even you ask the patient to breathe pure oxygen, it can increase only by 1.6%. However, you put a patient into a hyperbaric chamber, you put the patient under pressure, 1 or 2 atmosphere, this oxygen diffuses into the plasma. So now the oxygen that goes to the tissue not only goes through the RBC hemoglobin, it also diffuse into the plasma and that delivers to the tissue. That's the advantage. But very important that you do not use hyperbaric treatment unless you revascularize the patient first. I'm quite familiar with hyperbaric medicine because I was the army surgeon and I used to run the hyperbaric chamber for 7 years in Lumut. So we treated a lot of wounds using this hyperbaric, diabetic foot. But you must always ensure that there's blood going down, otherwise it will not work.
So coming back between negative pressure dressing and the hyperbaric, has there been any trials to say which is superior?
Not really, because hyperbaric treatment is not easily available. Whereas now the negative pressure dressing is quite easily available and now many people are using it. But certainly even compare negative pressure dressing versus a standard dressing, you find that negative pressure dressing is much more better, the efficacy-wise better. However, the cost also increases. But when we consider the cost versus standard versus a negative pressure dressing, you find that if you have to do dressing once a day versus you do dressing once in 5 days, at the end of the day, you find the cost actually evens out. So I think these days, modern dressing certainly has got a role.
Hyperbaric treatment and your negative pressure dressing is completely two different ways of approaching a wound.
Different ways,
completely
correct.
different.
Correct.
Is as a GP, is negative pressure dressing available?
Yes,
to
yes,
me?
yes. Yeah, it's easily available. In fact, they have got vendor who does this negative pressure. They can come to the clinic. They can actually do the actual dressing for you for the patient, and then send the patient home, advise the patient what to do. Then 5 days later, they come back. Then together with you, they open up the dressing, and then you decide whether you want to continue or not to continue.
It's a portable vacuum.
Yes,
device.
yes, it's just like one of these ready vac machine, but it's a portable.
How many vendors do they have in?
The wound care industry all over the world is worth something like 10 billion US dollars turnover. It's a big thing. Yeah.
Let me ask you a question. I mean, diabetes mellitus is very common. As a general practitioner, I've seen many diabetic patients. I'm sure my diabetic patients will turn up in my clinic where there is inadequate perfusion down the leg. Maybe I'll see a small ulcer. Now, and I see a bit of infection. Now, after listening to a lecture, would it be appropriate for me to say, okay, I've listened about negative pressure dressing. Let me apply negative pressure dressing. Would that be an appropriate approach, or should I send my patient to someone like you to have an evaluation of how the perfusion is first, ensure the perfusion is adequate before I venture to negative pressure dressing? How should I choose?
Okay, thanks, Kanan. I mean, that's a very pertinent question. I remember in medical school, what we learned is there are two things you have to know. One is the main therapy, one is an adjuvant therapy. For instance, when you have a breast cancer, the main therapy is mastectomy, either white excision or you do a total mastectomy. Adjuvant therapy is chemotherapy, hormonal therapy, radiotherapy, etc. You do not mix between the two. So if you have a diabetic foot infection, always remember there are three components. One is maybe there's adequate blood flow, but it's mainly due to infection that you can treat. Secondly, there's an ischemia. So you have to treat the ischemia first. Or third one is due to peripheral neuropathy. These are the main therapy that you have to tackle. Dressing is an adjuvant therapy. It's just like paddy field. If you have no water going down, there's no point you buy lots of expensive fertilizer, all kind of expensive, and then the wound would not heal because there's no perfusion down.
Okay, sorry.
Yeah.
You have shown us the three causes. Wow. So number one, you said the vascular. So if you can feel the foot pulses, possibly this is small vessel ischemia. What can we do for small vessel ischemia? Number one. Number two, neuropathic component. What can I offer as a GP to my patient for the neuropathic component?
Thanks, Jay. That's a very, very good question. So infection, you can do something. You can do IND, you can do a debridement, put a patient on antibiotic, that you solve the problem. If you have an ischemia, there's no pulses and all that, so you have to establish blood flow down. So you have to refer the patient.
Correct. A small vessel.
Okay.
I can feel the pulse.
Yeah, that's fine. Even those microangiopathy usually is not the main component in peripheral artery disease. Neuropathy, sometimes you got ulcer that's non-healing. What you need to do is actually offloading, in which case patient will be well served by referring to a podiatrist. Because podiatrists will take a look at the patient, establish their gait and all that, and then the thought of some way of advising the patient how to offload, either using some kind of a foot wear or advising on, so there are many ways that you can do. So send to a podiatrist.
So basically, for pressure to try to alleviate putting pressure on the foot.
That's correct. Yeah. So podiatrist actually plays a very big role. Yeah. In this case, in peripheral neuropathy. Yeah. Okay, so it looks like he was with us for about 2 months, and then subsequently, actually, he made it home. And then I think I've asked Kanan to actually he didn't come back again as usual, so he probably went back to Kanan this time. Switch to Kanan.
So he
or Kanan can use my slide. It doesn't matter.
Okay. So he has been coming regularly for follow-up. He remains a really very big size. He hardly walks at home, in spite of recurrent scolding. But he survived. We saw him last just about 2 months ago. He walks a little bit at home. Blood pressure is better controlled, 110/80. His atrial fibrillation is also better controlled. The stump is healthy. These are his current medications: rate control, anticoagulation, some offloading as well. Sometimes he's able to tolerate BPs better. And recently his blood sugar has crept up. We have started him on diabetes medicine. That's how his foot looks like now. He's able to walk around. He's got a special shoe for it. And these are his echocardiograms. LV's systolic function certainly is much better. We've talked to him about getting his coronary studied, but knowing him will procrastinate. I hope he doesn't come in with an acute infarct. It would be a nightmare to treat someone as obese as him with an acute problem. Back to you.
Yeah, maybe you can come on to my slide here. Okay, so we were discussing just now, trying to make a diagnosis of acute ischemia or chronic ischemia. I think this is really important because, quite unfortunately, sometimes we find people with acute limb ischemia, the diagnosis is missed. So by the time they refer to us, they come to a stage of irreversible ischemia. So there isn't much one can do about it, except just go for amputation. And sometimes the amputation is an above-knee amputation. So actually it's quite drastic. The other thing we need to know about this thing is chronic limb-threatening ischemia, which is a chronic ischemia that now has become acute. So they call it chronic limb-threatening ischemia. In the past, we used to call this critical limb ischemia. But as you know, a bunch of physicians and surgeons sit together, decided that we should come up with some global vascular guideline. And now they say the term chronic limb-threatening ischemia is preferred over critical limb ischemia, as the latter implies threshold value of impaired perfusion rather than a continuum. So chronic limb-threatening ischemia is a clinical syndrome defined by presence of peripheral arterial disease in combination with breast pain, gangrene, or lower limb ulceration more than 2 weeks duration. So this is the definition of chronic limb-threatening ischemia. But in this case, we are not talking about chronic limb-threatening ischemia. In this case, we are talking about acute limb ischemia. So I thought I would elaborate a bit more on acute limb ischemia. So in clinical practice, there are 4 types of acute limb ischemia they present to us. It could be embolus, it could be thrombosis, it could be trauma, and also aortic dissection. Embolus is obvious, usually happens with people with a valvular heart disease, people with atrial fibrillation, etc. Thrombosis occur in the older age group of people who sometimes may start off with claudication, and then at some stage, the stenosis or occlusion is so severe that they become decompensated, so they present acutely. So there's thrombosis. Trauma, obviously, there'll be a preceding history. Aortic dissection is something quite common these days, and sometimes they can actually present with limb ischemia. So I thought I'd just use some examples of, say, in this case, it's actually thrombosis. So this is a man with initially presented with claudication, and one fine day, we find that he wakes up from sleep, leg become very cold, very painful. He's not able to walk. And when you do a catheter angiogram, you can actually see there's actually up to the tibial arteries are okay, but very poor runoff into the leg, into the foot. And then what we did was we did thrombolysis of this patient, and after 6 hours thrombolysis, you find that these vessels open up again. In which case, then we follow up with some kind of angioplasty so that the flow can be sustained.
So this is due to thrombosis on
top of a chronic peripheral artery disease. That's right. These are commonly used thrombolytic agents. I'm sure the cardiologists are very familiar. Streptokinase, urokinase, RTP, etc. I'll not elaborate on this, but normally when a patient comes to us with thrombosis, we will do a CT scan, and then we put a patient on say catheter arteriography, and we put a patient on some kind of thrombolysis over 24 hours. And next day we bring the patient down to look at the angiogram again, and then if there's areas of stenosis, then we do angioplasty. That's what we do for thrombosis. The other cause of acute limb ischemia is actually aortic dissection. You can see this actually a lateral view. This is a sagittal view of ascending aorta. And what you're seeing, this line on this aorta is actually a flap. A false lumen goes dissecting all the way down. So as the flap dissect all the way down, you can actually suddenly cut off one of the iliac arteries, in which case patient can present limb ischemia. So this is something sometimes not well recognized. So in cases like this, we can actually try to open up this. We can do a fenestration of this flap. Then you can increase flow to the leg, or sometimes we have to do a femoral crossover.
Fenestration means what do? You poke holes in the flap?
Yes. As you go to a femoral artery, you poke through the flap.
Essentially, blood flows from the false lumen to the true lumen.
True. Yeah. Another thing we need to recognize is a patient can present with acute limb ischemia due to thrombosis of the previous maybe undiagnosed popliteal artery aneurysm or femoral artery aneurysm. The commonest is still popliteal artery aneurysm, but thankfully popliteal artery aneurysms are uncommon except in very old people. So these people are usually 80 to 90 years old. So when they come in, they can present acute limb ischemia, and when you examine them, there's such a bulge in a popliteal fossa. In this case, we did a femoral popliteal bypass, and then patient became okay.
Just for interesting, as a general practitioner, sometimes when I examine, say, the popliteal fossa, I see a bulge. It could be a Baker's cyst, and I think it's a Baker's cyst.
Yes.
How do you differentiate Baker's cyst from an aneurysm?
Baker's cyst, most of the time you can actually feel the bulge here. In fact, Baker's cyst is more common than a popliteal artery aneurysm. In popliteal artery aneurysm, as you feel the pulse is very prominent. Yes, you could see, I could feel the popliteal artery so easily. So you must be careful that that could be underlying popliteal artery aneurysm.
So there'll be a clue for me to refer to you.
Yes, in this case, I think if you are not sure, just put an ultrasound, you can see very well. A duplex scan, you will immediately see it. Yeah. So I was trying to emphasize on these categories of acute limb ischemia. And so if you have a case of acute limb ischemia, if you are from, say, outstation, maybe you're from Kuala Pilah or things like that, and usually we'll ask you, what do you think, is a limb viable or not viable? Viable limb, there's no sensory loss, patient can still walk, there's no weakness. But when it comes to category 3, it becomes irreversible. In that case, you find that it's really profound sensory loss and patient's paralyzed. That's a very bad sign. And also when you look at the skin, there's a fixed mottling of the skin. And in those cases, they actually reach irreversible ischemia. So we do receive sometimes patients from outstation, maybe not due to the GP's fault, because they have referred the patient, asked the patient to go to the hospital, but instead of going to the hospital, they went for other therapy, alternative therapy, and then they come in about 48 hours later. So by the time you look at the leg, it's irreversible ischemia. If you were to go in to try to reperfuse, then they get reperfusion syndrome. Reperfusion syndrome, they can actually die on the table. They get arrhythmia, severe metabolic acidosis, acute renal failure, etc. It's very complicated. And the worst thing is sometimes these patients are very young. They are in their 30s, in their 40s, and suddenly the limb have to be cut off. So it's something quite bad. Yeah. So very often sometimes we feel very sad that perhaps people don't pick it up early enough. Arterial emboli, most of it are from cardiac causes, atrial fibrillation, maybe had a myocardial infarct, there's some akinetic segment, LV aneurysm, etc. They are very, very uncommon. Non-cardiac causes are the peripheral artery aneurysms, or maybe iatrogenic, or could be paradoxical embolus coming from the right side into the left side. These are actually rare causes. Thrombosis is due to arteriosclerosis, aneurysm, etc. Commonly due to rupture arterial plaque, the severe stenosis artery. Just like you get the acute coronary syndrome, the same thing. You can get from occlusion of femoral or popliteal artery, aneurysms, trauma and iatrogenic injury can also cause thrombosis. In arterial embolus, this is a classic picture. They say a reverse meniscus sign. So when a doctor do arteriography, you find that there's a reverse meniscus sign. Meniscus usually goes this way. Reverse meniscus goes the other way around. And then there's actually no runoff into the foot. So that's a very classical. So this is a clinical picture of a person that presents with lower limb ischemia. You find that one side of the leg is very pale. So very important when the patient has got any leg pain, take out the shoe, examine it and feel for the pulses and feel for any temperature changes. In acute limb ischemia, you can often pick it up. The leg becomes very pale and so you couldn't feel the pulses. What we do most of the time, diagnosis is clinical. We can actually do a Doppler, measure ABSI. Usually there's no Doppler signal at all. We can do a duplex. We can do a CTA or catheter angiogram.
What when you say about the ankle brachial index, can you tell us something? I mean, as a GP, how I in my GP practice can do an ankle brachial index?
So in ankle brachial index, you need a Doppler. So basically, from the Doppler, you can record a signal in the, say, posterior tibial artery or dorsal spinalis artery. Then you will put the BP cuff, you inflate it to the maximum, and then you release the cuff. Once you hear the signal, so that becomes the sacral pressure of the ankle. Then you measure your blood pressure in the arm. Then your ankle pressure over your brachial pressure, that becomes the reference. So most of the time, arm pressure, ankle pressure are the same, so the ratio gets 1. But we allow some differences. So up to ankle brachial pressure is 0.8 is still acceptable. Anything more than 0.8, you think patient has got peripheral artery disease. But if the pressure goes down to the ratio of 0.4, then patient reaches a stage of chronic limb threatening ischemia. But in acute limb ischemia, there's no Doppler signal at all because there's no collaterals.
Okay. Doppler, I mean, how do I get a Doppler as a GP? How do I get a Doppler?
Okay, that's a very good question. My students in the university always ask me this question about how to get a Doppler. So I ask them, do you have a handphone? Yes. How much does handphone cost? They say, mine's iPhone 7 costs about 7,000 to 8,000. Doppler is cheaper than that. It costs about 5,000. So there's no reason why you don't have a Doppler in the clinic if you can afford a handphone. Yeah. And these days, it's a technological world now. And many people have got a duplex scan in the clinic. Not a duplex scan, they buy a probe for eBay or maybe from whatever, Alibaba, whatever. You go and buy then you can download the program in the internet. So then you use your probe that costs nearly $1,500 US dollars. Then from there, you can actually see the blood flow in the artery. That's a duplex scan. So these days is very technology driven now. So it's good to learn some of these things. You can actually learn it there are a lot of courses being conducted by radiologists, by vascular surgeons in order to do how to do a duplex scan on the blood vessel on the vein. So I think this I think we have to keep up with the technology.
Do you think in future, as a GP, I miss ischemic ulcer, and I've been sitting on the patient thinking it's an infective ulcer because I didn't do a duplex scan or I didn't. Can I be sued?
Oh, I think yes. I think you are probably liable because these days patient become very they are more and more educated. It's just like one of my patient, the parents develop a pulmonary embolism, and so they do Google search pulmonary embolism, and then they find the first sentence is pulmonary embolism is the commonest preventable hospital condition. Then the hospital becomes liable because they did not prevent it. It's stated on the Google. You can actually see it. Yeah. So maybe it's a and it's a good device to have, but you're not sure. I think probably it's safer to refer you if there's any element of doubt. Okay, I just carry on. All right. So management indication, well, acute ischemia contraindication, I referred to, mentioned just now that reperfusion syndrome that we are worried about. So sometimes we don't have a choice. Young or old, we still have to go ahead to do amputation. So this cubital fossa is very easy. You can look for brachial artery. You can do it under local anesthesia. For upper limb, embolism. Yes, embolism also occurs in upper limb. This femoral triangle, very superficial. It's very simple operation. For us, we can isolate femoral artery, point the embolectomy catheter, and fish out the clot. This is principles of what we do. I think I'll not elaborate too much on this. But basically, is we make an incision over the groin. We find superficial, the femoral artery is very superficial. We isolate it. We make a small arteriotomy and put in embolectomy catheter. We fish it out. So an embolectomy catheter, when it goes down, is actually flat. And you inflate the balloon distal to the embolus, and then you pull it out. The whole embolus comes out. Then you put it on the clamp. In fact, this is called Fogarty balloon catheter, invented by Thomas Fogarty when he was a medical student. And this is actually a very useful device. And I teach this, most college surgeons, I like to teach this to the surgeons because I always feel there is no simpler surgery when done in a timely manner can prevent so devastating a consequence. This is what I like to quote to the students. Yeah. Anyway, just one more slide to show you that this is actually a recent case, a 94-year-old woman who came to KL from Kelantan. She's Dr. Su's patient. Is on hypertensive, ischemic heart disease, has atrial fibrillation, also a bit of renal impairment. And came to KL, then didn't bring the apixaban. So she stopped for about 9 days. Then suddenly came one midnight of night, she came with pain from the shoulder to the hand. And when they came to ER, they find the hand is blue. But then when I elevate the hand, you find the hand is hand is white. So embolus can actually go to the upper limb. So in this case, we quickly bring a patient to the operating theater, did the embolectomy. At the same time, because embolus is quite stuck, I did the on-table arteriography. You find that the thrombus is all the way, the embolus is all the way stuck in the subclavian artery. And we managed to fish it out. And so you find that the hand becomes immediately normal. One could imagine that if you misdiagnose thinking that this is just a bit of neuropathy, then patient can lose a limb. At 94 years old, I think they won't be pleased if they lose the limb. In this case, I think this is about acute limb ischemia. I think we should give thanks to early diagnosis so that patient can then walk the trail, enjoy those wildflowers, and then back to normal life.
Great. So coming back to the both of you, what take-home message could you give to the GP when we treat the patient? Or maybe start with Kanan first.
My only contribution here is clinical examination. We're always told expose the patient completely, and often we don't do that. Sometimes patients don't take off the shoes, sometimes patients don't take off the stockings. We must make sure we do that. Often the examination is on the face, the chest, the abdomen. The lower limbs are often missed, so you can even pick up things very early. Patients often say, "Why do you touch my feet, doctor? Are you praying?" I don't know. We're feeling the pulses in your feet, as it's a very simple examination to do. If you have got absent pulses, it's something that we have to check. So especially in patients who present with pain, don't think that it is just arthritic pain. I mean, something so sinister. And we don't have to do anything very fancy. You don't need a $4,000 equipment, just your fingers. Feel the pulses. If they're not there, a lot of things to do. So my contribution is adequate exposure to simple examinations that are taught in medical school.
And I guess also look to find out whether it's an irregular or regular pulse, because
yes,
if it's irregular,
big contribution. Well, one thing while we're talking about this, Dr. Liu, we talked about patients having pain in the lower limbs and absent pulses. And we say, okay, this is peripheral vascular disease. What if you have got a patient with classical pain in the lower limbs? When I walk, I got pain. And you say, okay, this must be peripheral vascular disease. And then I go and feel the pulses of the feet. The pulses are very good. Could there be an alternative explanation for this?
Yes, that's very common because not everybody with pain in the feet is due to peripheral artery disease. One of the common cause of this pain is actually, we call it people with a spinal stenosis or prolapse intervertebral disc. And so for claudications like this, we call this spinal claudication. It's quite typical that you can distinguish between a spinal claudication versus an arterial claudication. In arterial claudication, they can walk for a certain distance and usually quite a fixed distance. And you can roughly tell them, if you go to a market in the morning, how many shops can you walk? So he says, every 10 shops, I need to stop. Every 10 shops, I need to stop. So there's a fixed claudication distance. But spinal claudication is different. In spinal claudication, you find that there's no fixed distance. And then sometimes they get up from sleeping, sitting, they start having a pain. And then they couldn't walk. You find that walk a few steps, they get pain. And sometimes the thing did not occur. So in those cases, a spinal claudication. Now remember, our leg, especially the medial aspect and lateral aspect leg, is actually is supplied by L4 and L5. And this is the common site where you get a prolapse interval, this L4, L5. And there's sometimes the pain can be there. It's actually due to spinal nerve pain, not due to claudication.
This can occur even without a back pain?
Usually there will be some back pain, but they may not notice the back pain because the pain in the L4, L5 area is very severe. But typically this patient will have some kind of sciatica. The pain is not just at the calf, they actually radiate down from the buttock all the way down.
What about, is it possible that it is a microvascular angina? That it is just due to small vessel disease and, the pulses that we feel is okay? Could that also be a contributory for the intermittent claudication?
Very unlikely, because microangiopathy in a small, because our muscles in the foot and all that, they have a lot of collaterals. So if you have microangiopathy, a small area, very unlikely, because there's still a lot of collaterals coming out. Unlike maybe in the eye or in the kidney. And those microangiopathy, because to start off, those vessels are very small. They can actually cause a fibrosis and then you go to lead to nephropathy. So they're quite different.
Right? One other thing I've got to ask is, suppose I do feel pulses. Maybe the pulses are not that strong, but they're present. Could just collaterals cause the pulses to be felt and yet the patient still has significant ischemia?
Usually, yes. But the wrong thing to presume is that if you have a Doppler signal, that there's no obstruction. Your Doppler signal could indicate collateral from coming in. But you can feel a pulse, you are not quite sure in the lower limb, you can compare the radial pulse. You can compare. You find that the pulse is a bit impaired, then maybe there's some amount of ischemia. So I think one has to be careful.
Okay, what about the other things? Suppose I cannot feel the pulses. I look very hard, cannot feel the pulses, but the patient is completely asymptomatic. Okay, what should I do, or what sort of advice should I give the patient?
Well, if the patient is completely asymptomatic, one has to be careful because sometimes patients may not be walking due to their cardiac condition. They're in heart failure, so most of the time they are not walking very much, so they may not even know that they have a claudication. So in those cases, you find that you can treat the main condition first, the heart condition. Yeah.
Let's assume they don't have that. It's just that incidentally you find that they cannot feel the pulses, but the patient is asymptomatic.
Okay, so in the patients, we all know that if you have a significant peripheral artery disease, there is often association with coronary artery disease and cerebrovascular disease. So if you were to look at a pool of population or follow them over a period of 5 years, those with peripheral artery disease, maybe up to 5% of them may lose their leg. But 30-40% of them will die of coronary artery disease. So in patients like this, you find that I always tell the patients that your artery in the leg reflects the artery in your heart and your brain. So it's better get your heart checked.
Okay, so they will come for the heart check, and so specifically for the leg, you are really not going to do anything except to control your risk factors and stop smoking. I mean, you wouldn't want to go and do an angioplasty because it's completely asymptomatic.
You're right, yeah.
But I do have patients who tell me that, hey, if you don't improve the blood supply now, suppose I get an ulcer next time, I may end up losing my leg.
That's true, because when we intervene, we always need to think that if you put in a stent, the stent can actually get in-stent stenosis, If you do a balloon angioplasty, again, there could be internal hyperplasia, and then the thing can recur. But you insist, tell the patient that you've got significant peripheral artery disease, you go for exercise, you keep walking. So what will happen is the collaterals will open up. Unlike the heart, you can't exercise your heart, but here the lower limb you can exercise. So many patients, when we put them on some kind of a conservative therapy using, say, cilostazol, lethal, or maybe antiplatelets, and then ask them to go on an exercise program, you find that they can actually walk quite a long distance. In fact, I always give them a specific target. Let's say they live near a football field, they can walk one round football field, they have to stop 4 times. By encouraging them, putting on some medical therapy, you find that they could walk the whole round, only stop once. And then next time they could walk 2 rounds without stopping. So they become very happy with the exercise therapy because they can see the target.
So basically, you would only intervene by angioplasty or something if there are symptoms or if there's evidence of an ounce. Otherwise, just medical therapy, like you have mentioned.
That's true. You see, every disease that we intervene, we actually look at the natural history of this disease. In a person with claudication, in 5 years, less than 5% will lose the leg. But if the patient has reached a case of chronic limb-threatening ischemia, if we don't intervene, in about 2 years' time, half them will lose their leg or half them will lose their life. So in that case, we know the natural history. That's why we have to intervene.
Okay, there are some questions.
So we will think interesting discussion, but we should let the audience also ask questions. So we've got a few in the Slido. Okay, so there is first question: can negative pressure be used for diabetic wounds?
Yes, certainly. Like I say, negative pressure is an adjuvant therapy. You always treat the main therapy first. You find out what's the main problem is. Due to infection, you have to do an IND, you have to put the patient on antibiotic, etc. And if it's a peripheral artery disease, you have to revascularize, neuropathy, you have to offload. And then dressing is a form of adjuvant therapy. It's an adjuvant therapy.
Yeah. Right. Second question: some obese patients have feeble dorsalis pedis, but their color of the feet are normal. Can this feeble pulse be ignored? So it's feeble because they're obese.
Yeah. If you're not sure, what you can do is you can actually do an ankle breaker systolic index. You compare both sides. If the both sides their normal ratio is 1, then you don't have to worry about it. They don't have a peripheral artery disease. So like I say, we don't make a diagnosis based on one sign or one symptom alone. It's a constellation sign and symptom. If we are not sure, we actually get a ABSI. It's a very useful device to have.
But you need a Doppler.
Yes, you need a Doppler to
You
measure.
can't use a stethoscope.
No, you can't use a stethoscope because you can't hear the flow in the ankle. Yeah,
Okay,
you need a Doppler.
I have to forego my next iPhone upgrade to buy a Doppler for my
Okay.
Okay, so maybe we are coming to 3 o'clock, but very interesting and a lot of questions. But we have to call it a day. So there's one last question: how many days can a patient stop his anticoagulation and be still safe? So I suppose we restrict it to AF because there are many scenarios. So cardiologists want to.
So generally, most of the new novel anticoagulants we use, generally about 48 hours they last. Like they need to go for surgery, it's about 48 hours. Depending upon what risk factors for embolism they have, we will usually want to give some sort of bridge therapy like heparin will give, and then stop it just before surgery, get the surgery done, and restart anticoagulation as quickly as possible. So the important thing is, if the patient is on anticoagulation for a very important reason, it should not be stopped unless there's a very good reason. That too, we should bridge, watch, and restart as quickly as we can.
I think these novel agents are very short half-life. Unlike warfarin, you stop also, you still go on for days, whereas like some of them even less than a day, they're worn out. The risk is more for stroke, that's why they are given. So I suppose you can also calculate the CHAT-BET score to see those very high risk. You may definitely want to bridge those low CHAT-BET score.
Especially the past history of embolism or stroke, you don't want to be very careful about something.
Generally, like 48, 72 hours would be.
About 48 hours.
So
Yes.
the lady was 8 days, unfortunate,
Yes.
but she was so fortunate that with early intervention, save her. What is your quote again? Your quote. Early.
Okay, there's no simpler surgery
Yes.
that when it's done timely can have such a devastating consequence.
Yes, I think that case really illustrated it and what a great outcome she had. Yeah. Okay. I think we have to call it's 3 o'clock. We will move on to the final bit, which is the CPD point section. Okay, I've got some message how to claim points. Remember, you cannot scan the points with the MMA app. Okay, do not scan with the MMA app. This is the link. You scan this with a camera app or a QR code app, and it will take you to a Microsoft form link for you to submit attendance. Okay, so open your camera app. Let's see. Okay, and it will take you to an office form, and you enter your details there, your name, your IC number, MMC number, place of practice, location, all that, and you submit it, and then the SJMC team will upload your attendance in about a week. Okay, if you have any issues, please contact the SJMC attendance. The other thing is also you can add a comment to our YouTube. You have a problem, and we'll get back to you to help you get your point. So basically, thank you everybody for watching. We hope you enjoyed this session. Like in everyone, we learn a lot from each other, our cases, and from each other as different disciplines. We hope that our sharing has also benefited your practice, whether you're a specialist or a GP. Okay, so if you have any issues, just leave a comment, or you can contact the SJMC team in their WhatsApp group, and we'll help you upload your point. Okay, so thanks,
Thank you.
Kanan.
Have a nice weekend.
Thank you, everybody. Thank you very much,
Have a
everybody.
good
Nice
weekend,
weekend.
and see you in the next one. We'll announce, but please do subscribe to our channel so that YouTube will keep you informed. But we also try to reach out to you in our DOPS social media, Facebook, Telegram, and also now we're sending out WhatsApp to remind each one of you of our upcoming live streams. Okay, so have a good weekend, everybody. Take care. Bye bye.
Thank you very much.
Thank you.